Yeah. Okay, we can start.
Okay, perfect. Assalamu alaikum, everyone. Thank you for joining us today. We are really excited to kick off our When to Worry webinar, where we'll have a series of different physicians talking about when to worry about several different health signs. I know all of us in the past 2 years have been at home and emergency rooms have been closed or full. So we just wanted to make sure that you're all equipped with the knowledge to be able to identify signs and symptoms of important health events at home so that you're able to monitor your symptoms and seek care when necessary. So today we're really excited to present Dr. Humaira Ali, who is a board certified cardiologist in Washington State. And just a fun fact, Dr. Humaira was actually one of the first physicians to start working with the MAPS MCRC Community Health Clinic. So thank you so much for all of your time and your commitment to the community, Dr. Ali. With that, I'm going to pass it on to you so that you can introduce yourself and we can delve into the topic of when to worry about chest pain. Just as a quick note, we will have a Q&A session for the last 10 to 15 minutes. So if you're on Zoom, please use the Q&A button to ask questions, and we'll make sure to get to your questions as soon as we do the Q&A. Thank you again, Dr. Ali. We look forward to your presentation.
Thank you so much, Nihat. It's so excited to do this kind of work with you. Again, you're such a superstar in the MAPS community. And I wanted to talk about kind of what are all the different types of chest pains that people might experience and how do you know when to worry about them. It comes up a lot in my practice. So when people are sent to me by their primary doctors around their symptoms, we have to kind of do a little bit of detective work to sort through, what kinds of questions do we have to ask? What are we worried about? So maybe if people kind of know how to assess themselves a little bit, they can also be helpful to their doctors when they're trying to explain to them what they're experiencing. And that kind of helps with that detective work. So I'll kind of try to switch over to my slides, and that way we can see what some of my thoughts are here. There we go. So talking about chest pain today, how do we know when we're going to be worrying about our chest pain? I think the main focus is to kind of distinguish cardiac versus other things that people are going to feel for chest pain. Oh, and so it's not converting over to my next slide here. Let's see. Maybe I'll go at it this way. There's a way I can switch over. Okay, I'll go this way. So chest pain, doesn't want to switch. Of course, it works really good when we're doing the test run. Okay. Are you guys able to see this if I don't go to the slideshow mode?
We can't see your slide right now.
Can you see it now?
Mm-mm.
Oh, okay. It was working before, right?
Yeah, it was working before.
Ah, shoot. Okay. So let me do this. I'm going to maybe just kind of talk about it then. So there are many different organ systems that live in our chest, right? We're going to have our heart that's right in the center of our chest. We're going to have our lungs, our food pipe. So when we swallow something, right down the middle of our chest is our food pipe. Very closely related to that is the stomach. It's going to be just a little bit over towards the left side as well. And so when it comes to pain and discomfort, any of those organ systems might be involved in that kind of symptom source. And so what we end up doing is try to kind of figure out a little bit where might that source be coming from. I think one of the really common misconceptions, chest pain that's coming from the heart, it's going to feel clearly different from other sources when there's actually quite a bit of overlap. So we're wired with nerves that warn our brain that something's not feeling right, but it's somewhere in our chest. And a lot of the symptoms might overlap, but sometimes there are clues that can help things along. For example, when it comes to cardiac type of chest pain, usually the pattern is kind of this all over sense that's kind of in the center of our chest. And of course, it can kind of radiate from there. So we might have that extension down into the arms, the shoulders, the upper back, even up into the neck, the jaw. Some people even talk about their ears being involved. So really anything from about the ears to the waist is a possible location that can be heart-related discomfort. But something that seems to be more consistent is that when it's the heart, it often is difficult to point to that pain like with one finger. It's never that localized where someone says, oh, I can feel the pain like right here. As soon as somebody talks about it being that localized, like I can feel it here or right here, it makes us think that maybe it's actually a different type of pain than cardiac. I think the words that are used in describing cardiac type of symptoms tend to be words like pressure, pain, tightness, heaviness, oppressive, like it's got this feeling of pressure combination with their pain, discomfort, rather than something that's sharp, electric, stabbing, pinch, when it's really localized, when it's fleeting, like it's just there for a second and gone, we tend to think that it's not common for heart to feel that way. So I'm on the lookout when people are describing their symptoms for things that are a lot more all over rather than localized where they can point to it with one finger, for example. Pains that are lasting in duration that go up into many minutes are more worrisome to me when I listen to that story than someone who says it's just there and gone for a second. It might keep happening, but if it's just there for a second, then I'm thinking about other sources. Other clues are that because we were talking about how the food pipe sits in the center of our chest and can cause discomfort too. Usually if somebody says, oh, the discomfort is worse when I swallow, I'm going to think, oh, swallowing is going to maybe mean that it's related to the food pipe or it's esophageal or related to the stomach somehow, as opposed to heart, which tends to bother people more when they're doing something physically exerting. So when you make the heart work harder, that's when it's going to complain louder and people are going to feel more intensity or an increase in the pattern when they're doing something aerobically or physically more exerting. So those are some of the kind of clues or ways to distinguish it a little bit. We were talking about lungs as also being kind of tenants of our chest, and that can also be a source for discomfort. Interestingly, because often what might hurt with lungs involves the lining around the lungs or the stretch that's put on the lungs when we take a deep breath in. When people's intensity of their discomfort increases, when they take a deep breath in, it makes us think about things like pleurisy, inflammation of the lining around the lungs, and there's lots of things that can cause that, various diseases and infections even. But one of the worrisome things that relate to lungs can be when we happen to make blood clots that can travel from our legs, especially where they're often formed, or like a deep vein thrombosis or DVT for short. And that clot lets loose from the leg, travels up, goes through the heart, and lands in the lung. Those can be deadly problems. And so it's important to kind of get attention immediately when we feel a sudden pain that is worse with the deep breath in. So those are a reason perhaps to go into the hospital. So cardiac discomfort tends to be something that is more worrisome when it's triggered with exertion, with kind of going upstairs, going up an incline, hurrying our pace. So we're feeling it more when we pick up some physical exertion, and that tends to be a warning to make sure you're bringing it to your doctor's notice. That is definitely something you don't waste time on, and you bring it to somebody's attention that it's happening. And if it were to ever increase in the intensity, or how long it lasts, or how often it's happening, or how easy it is to bringing it on, those are all reasons to actually bring yourself to a hospital setting. Emergency rooms are equipped in trying to figure out if this is cardiac or not. And if it happens to be cardiac, then they have a whole series of things that they would do to make things safer for you in a more immediate basis. So time becomes really important to not waste if in our mind we're thinking it could be cardiac. And I think just as a rule of thumb, if you're getting a pain that you are not used to having, this is really new to you to feel this, it's always good to err on the side of caution and get checked out. And just kind of to step back a minute around the anatomy and just the reasons why heart would hurt. Typically why the heart causes chest pain for somebody is when the blood supply that's coming to itself to be a good muscle and a good pump for your body, that blood supply is disrupted somehow. And usually the most commonest reason why it disrupts is when a blood clot or a piece of plaque grows, which is like cholesterol buildup inside the arteries that feed the heart itself. When that cholesterol pile grows inside the artery, it can grow in a way that the blood flow is being choked off or cut off, and then that muscle of the heart doesn't get the blood supply that it needs. And so it's like a cutoff of fuel and oxygen and nutrition to itself. And that's what really makes it symptomatic and makes it hurt and cause problems. So one of those more common ways is for plaque growth or a blood clot to form inside. But another way might be when the artery goes into a spasm. And a spasm is just when it clamps down on itself a little bit, and that diminishes the blood flow trying to get through. And it happens more commonly with certain kind of drug abuse, like for example, cocaine, which can constrict arteries and they can go into spasm and cause chest pain, and all the way to even having damage, which is what a heart attack is. And then the other reason that is becoming more recognized recently is that syndrome called broken heart syndrome, which is usually when an intense emotion, anger, grief, bad news suddenly creates a surge of adrenaline, and our stress hormones come pouring out, and then that can send the artery into spasm. And that spasm can actually cause the same symptoms as a heart attack, maybe even damage to the heart muscle as a result of that, and would also be a reason to go and seek help immediately with what is a 911 call. So 911 is where the ambulance comes to you to assess you immediately as to what's happening and to waste as little time as possible to be brought into the hospital and get taken care of. So I think with that kind of basic work through of the different types of chest pain patterns, I can turn it over to any questions.
Thank you so much, Dr. Humaira, and for improvising, given that the slides weren't working.
I know that's silly, but it's mostly just my usual talk anyway to people.
Thank you. There are actually a few questions here that we can get into. The first is, are there gender differences between how a heart attack is manifested in a man versus a woman?
That's a great question. I was hoping somebody would ask that and start off with that. So the way I think about it is that when we hear the typical symptoms of a heart attack, I think what that is an average assembly of everybody's collective experience. For example, I think the most common things that we hear about are chest pain, that's a central pattern that can go down your arms or up into the shoulders, jaw, neck, and that would signal to everybody who feels it that something is terribly wrong. But an individual may feel only some aspect of that. There will be people who only feel the discomfort, say, on exertion in their jaw, but they don't have a good reason for it. It's not like they have a toothache or a problem in their jaw, and yet every time they go up the incline, like say to their mailbox, they're going to feel their jaw hurt. Similarly, I think depending on how we're wired, depending on what we pay attention to as an individual, and that might be where gender differences come in a little bit, how we interpret our discomforts may be different. And it might not even just be gender, it might be even race or cultural in terms of how we interpret the symptoms and how we represent them to the doctor. But I think the listener, the provider who's hearing the story, puts it all together and may even sort of process the risk factors that the person brings with them. Like if somebody has a lot of family members with heart disease, they're going to worry about them more than somebody who doesn't have as much of a family history, for example. There will be people with different pain thresholds. And I think this is maybe where one of the gender differences is recognized, is that women may not exhibit or interpret the pain with a heart attack as much as a pain. They may feel it like, hey, there's something wrong with my breathing. I'm having to slow my pace. When I do the usual things, it's taking me twice as long. I'm having to stop and take a break to breathe more or breathe harder. And they may feel it like it's affecting their breathing. So a shortness of breath on exertion, even without the chest pain, is something that our mind is kind of tuned into listening for when we hear patients talk. I don't want to kind of have people think that women never get chest pain and men always get chest pain. I think it's all in the way we interpret all of the spectrum of things that we might feel is not behaving correctly, and especially on an exertional basis.
Thank you. I guess just in that same realm, at what point would a person seek medical attention if they are experiencing these symptoms? I feel like culturally, a lot of times people are just like, oh, I'll go lie down and hopefully everything will resolve itself. So at what point do you either call 911 or go to the ER or call a physician or nurse?
Yeah, great question, and a really good, important kind of thing to know. I would have said that any sudden pain that might not even be on exertion, like I'm sort of talking more about exertional pain because that's when we actually get a warning about it before something big happens. But sudden blockages of an artery feeding the heart muscle from a blood clot blob that gives you no warning it's about to form, but when it does, all of a sudden the blood flows shut down, can be at rest. And it is often a really significant feeling that something is terribly wrong. So when we feel a sudden new chest pain that we've never had before, and we're not sure what's happening, then I would say that as you begin to realize this isn't just lasting a second, and it's not one of those really localized things, it's actually following that pattern that we're just talking about here, that could be a 911 call. And the reason, again, for the 911 call is because you want to waste the least amount of time between the onset and the realization that something is wrong and getting into the hospital where they can actually figure out that this is or isn't a heart attack. We always feel silly when it's not and they discharge us, but that's a retrospective, like you put your hindsight glasses on and now you know it was nothing, but you don't know that it's nothing as you're feeling it and going forward in time. So it's always good to err on the side of caution.
Thank you. For those with blood pressure monitors at home, or those with like Apple Watches that tell you your heart rate, is there a specific heart rate to look for, or a specific blood pressure to look for where you should seek immediate attention, medical attention?
Yeah, and I'm not sure that this necessarily helps you in diagnosing the chest pain in that instance or not. But again, the beauty of having these wearable devices or having a blood pressure machine at home is actually to get to learn what your normals are. Because when you do it, when times are good and you're feeling well, you get to learn what your normal behavior looks like, what your resting heart rate normally runs at. What does your blood pressure typically look like? And then when it's not behaving according to your normals, then it's a good sort of way to judge, okay, do I feel well? Do I not feel well? And if I don't feel well and you're suspicious it's got something to do with an abnormal reading, then again, make the call to the doctor and have them help you sort it out. I wouldn't say that there's something that's a cutoff where I'd say, oh gosh, if you're over and above this or below this, that it's a cause to worry. But there are extremes to these numbers that would make everybody feel anxious that something's wrong. So for that, I would say blood pressures that are up in the 200 systolic, that's the upper number on the blood pressure reading. If you're hovering around there and it's not coming down, I would say, you know, it's probably a good idea, especially if it's causing you to feel unwell or symptoms, to get into a hospital and get it checked out. Heart rates, when you're just sitting there doing absolutely nothing and you're not anxious and there isn't like adrenaline pouring into this heart rate, I would say a heart rate above, let's say about 120, 125 with no good reason is going to be a reason to get checked out. And depending on how you feel, that will sort of dictate whether you should be maybe just calling your doctor after hours instead of an emergency room visit. But the more extreme that number is off your baseline, the more it might be something where you actually do go in and get checked out.
Thank you so much. The next question, kind of in the same question about heart attacks, is can you speak about silent heart attacks and where there is no pain but an attack is in progress?
Oh, what a great question. So silent heart attacks are generally something that affect people who don't have nervous systems that are working well enough to give you a warning of chest pain or discomfort. And I think the majority of that, the big percentage of people where that affects them the most is our diabetic population. And that's because nerves are not working as sharply in diabetes. And so sometimes they are all completely so silent that you don't even recognize that there's damage to your heart that's even happening. And it ends up getting picked up by your doctor in retrospect. But I think if you stop and pay attention a little bit to occurrences where you know you're not feeling well or not feeling right somehow, and it could be subtle, like in your breathing, there's some reason why you're feeling short of breath and you don't have a good explanation for it. Or maybe you are so intent on thinking that the chest discomfort is actually your stomach, that you begin to ignore that maybe it might not be your stomach. It might overlap again and feel completely different than your stomach's usual way of exhibiting a problem. And there's something about it that's not quite right. So it's good to stay in touch with your body to know when things are not behaving according to their usual patterns. And if you happen to think of yourself as at risk for a silent heart attack, which is the longer somebody's been diabetic for, the bigger that possibility exists because their nerves get worse over time. I think probably that's the population I would direct that attention to is our diabetic population.
Thank you. The next question is, are heart palpitations a precursor or a sign of an impending heart attack?
Oh, good question. So palpitations, if I just kind of define that a little bit, is when there's an awareness that the heartbeat is not doing its usual steady beating pattern. So heart rhythm, meaning the pattern with which our heart beats, is usually very steady. It's steady when it even rises and falls with activity, but it's got a very precise timing interval to it. Palpitations is anything that makes your brain aware that your heart's beating in some natural way. That could be either unnaturally fast, irregular and not steady, both, or just pounding hard. Like I'm aware my heart's beating hard, like an alarm bell goes off and now the adrenaline's rushing and you can hear your heart beating loudly kind of thing. Those are all features of the heart rhythm. They may or may not have anything to do with the circulation to the heart, which is what heart attacks come from. You can have a problem with your heart circulation and have an impending heart attack without any abnormality of the heart rhythm itself, or the heart attack that begins to freak you out when you're feeling it and now your chest is hurting and the adrenaline that pours as a result of that can also make your heart become like you becoming aware of your heart pounding or beating fast. So it can be part of the package, but a lot of the times it's completely separate. And we should do a whole separate session on palpitations because that's a really common symptom. And again, another when to worry about palpitations talk would be really good in that regard. But I generally think of them as separate than heart attacks.
Perfect. The next question is from an individual who says that heart disease is common in their family, and a few family members have died from heart attacks or heart disease at a young age. Is there something their primary care doctor should check annually?
Yeah, so when there's a recognition of family history, it is really important to discuss that with your primary care doctors. They look through the rest of your risk factors. They look at your numbers, like your blood sugar numbers, your cholesterol numbers, your blood pressure numbers. And there are many things you cannot measure, like how much did I inherit from my family? When does aging become a problem? How much does stress impact me? Those are all unmeasurable. So there are tools and tests that they can take you through to help tease apart how much should they worry about you, when is it the right time to start medications from a preventative standpoint. And primary care doctors definitely have some of those tools. They're not all on the same page all the time in terms of how aggressive they are about looking into prevention. If you ever feel like you're spinning your wheels with your primary doc, you can always come see cardiology.
Thank you. They're actually
Cardiologist before your heart attack, though.
great advice. But there are actually two more questions. I know we're getting to the end of our half an hour here. The first is, what do you do when a family member or loved one refuses to let you call 911 or seek medical treatment on their behalf when they're experiencing chest pain or other irregular cardiac symptoms?
Maybe this is a good conversation to have with them ahead of time. So if you recognize that they might be someone at risk because of risk factors, it's always good to work out a plan with them. Like they should know when the situation may be flipped, and you're the one who needs the help, and that they shouldn't be dragging their feet around it just because they don't want you to call on them either. So I think having these conversations maybe with even the doctors that you are going to see as part of your annual physical exam, so that everybody's on the same page and clear about what are the reasons why calling 911 is a good idea. Of course, there's always going to be the stoic people who even after the ambulance driver comes, they will say, don't take me in, I don't want to go. And at some point, you just kind of can't help them if they don't want to be helped themselves. But it is a good idea to always kind of plan ahead so that everybody's clear that these are clear indications why someone would be calling 911 on their relative, regardless of whether the relative thinks it's a good idea or not.
Thank you. And then the last question is regarding older adults. So a lot of families live with either parents or grandparents who are older and who don't necessarily like communicate the things that they're going through, especially when it comes to like chest pain. How do you distinguish between like regular aging pains versus like actual cardiac symptoms that need to be monitored or taken to the emergency department or to a physician?
That's a great question, because who doesn't have aches and pains? I don't even think you have to be elderly to have aches and pains. But I would say that being in touch with what somebody's baseline is, and then having an appreciation that something doesn't feel right or look right, or again, back to a familiarity for baseline, and whether something is not behaving according to expectations is probably going to be your valuable way. And a lot of that is gut. A lot of that's kind of the art of interpretation of how somebody's feeling and looking to you, and asking the right questions of that person. And I think for the most part, shortness of breath, sweating, nausea, not looking good, just the eyeball test of looking at somebody and seeing how they appear to you. Your basic tools around a heart rate, a blood pressure gives you some clues. And you can always call most doctors up even after hours to just have them troubleshoot with you what you think is not working right, and getting an advice from a nurse line or a doctor line around, hey, is this a reason to bring somebody in or not? So that's always a choice for most people who have a primary doctor.
Thank you. It looks like those are all the questions for today. Thank you so much, Dr. Humaira. Yes.
Oh, you're so welcome. Thank you again for doing this. We'll do it next time, inshallah.
Yes, inshallah, hope to have you back. And just to let everyone know, we will be having the second set of our When to Worry webinar next Monday, not Tuesday, March 7th from 6 to 6:30 p.m. And that's going to be with Dr. Marie Mercado, who is an endocrinologist. And she is also a volunteer of the MAPS MCRC Community Clinic. So we're really looking forward to having her and having her speak about diabetes management and when to worry about that.
And again, I was an hour later than I think all of your subsequent talks. So just so everybody keeps that time straight.
Yep, next Monday at 6:30 p.m. at 6 o'clock p.m. All right, thank you so much.
Thank you.
Have a good night.